Welcome, everyone. I'm Trish O'Neill with the National Pancreas Foundation. Thank you for joining us for the National Pancreas Foundation's 2022 Virtual Education Webinar Program. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, the NPF Cookbook and Pocket Guide, which is offered in hard copy as well as a free download, our patient registry, state chapters that support education, fundraising, and patient support, and our physician programs that include research grants, medical education, and our annual Fellows Symposium. Our success depends on the support of many individuals and organizations. You can make a difference by joining NPF as a volunteer, making a donation, or sharing your own personal story. Our topic this evening is ensuring a healthy pancreas, and it will cover diet, exercise, and lifestyle. During tonight's presentation, please use the Q&A section of the webinar for your questions, and we will address those at the end of the session. I'd like to welcome and thank our moderator and panelists, Dr. Keswani, Beth Dorfler, Dr. Hogue, Dr. Epstein, and Dr. Singh for supporting the mission of NPF. Our moderator is Dr. Rajesh Keswani of Northwestern Medical. Dr. Keswani is a gastroenterologist who specializes in interventional endoscopy and leads efforts to improve healthcare quality. He is the director of endoscopy for Northwestern Memorial Hospital and the director of quality for the Northwestern Medicine Digestive Health Center. Nationally, Dr. Keswani informs clinical practice guidelines and endoscopy training standards by serving on committees of the American Society for Gastrointestinal Endoscopy, the American Gastroenterological Association, and the National Comprehensive Cancer Network. He is both the medical director for the NPF Illinois chapter and a member of the board of directors of the National Pancreas Foundation. I'd like to thank you, Dr. Keswani, and all the panelists. And Dr. Keswani, the floor is yours.
Thanks, Trish. Thanks for making sure that we host this event this year. It's always been very popular, and it's a great chance to see friends from around the city, educate, and we can all learn from each other on a topic that we're all passionate about. And so I appreciate you and the NPF putting this together, and everyone on the panel who will be speaking tonight. Obviously very much appreciate their efforts in putting together some talks. My job is very easy today, which is why I chose it. I get to just introduce everyone and just sort of introduce the night's talks, but I get to do learning like the rest of you from our colleagues. So just a couple of, sort of introductory slides, just so everyone understands, and level sets why we're here. Everyone, actually understands this on the call, but perhaps, some of your family members don't, or some of your friends don't, and you want to sort of share these slides with them and just some understanding with them. And a lot of patients who have, relatively early on in their disease process, ask us, what does the pancreas do? Because, it's not an organ we think about a lot until it causes problems, but it is, as you all know, very critically important, right? It has two main components that we talk about with patients, the so-called exocrine and endocrine functions. You might hear that when you're in a clinic visit. The exocrine function is the fact that the pancreas produces digestive enzymes that help you digest not only fats, but also carbohydrates and other nutrients that you need. So when the exocrine portion of your pancreas isn't working well, you'll have malabsorption. You won't be absorbing your food well. We'll hear a lot more about that today. And then very importantly, it has the endocrine function. It produces insulin so that we can help manage our blood sugars, a very critical importance. And so something else that can be affected with pancreatic disease or pancreas surgery. And there's a lot of diseases of the pancreas, and that's why the NPF is such a unique, organization, because it is interested in all areas of pancreatic disease. The things that we see the most in our clinical practices on this panel will be things like acute and chronic pancreatitis, pancreatic cysts, pancreas cancer, and people who need pancreas surgery for any of these diseases as well. And so all of these diseases can impact both the exocrine and endocrine components of the pancreas, but also can cause symptoms that you'll hear about, including pain, and how we manage those symptoms is really important. And that's, again, one of the things I want to highlight tonight through our expert panel. The reason we and the Illinois chapter of the NPF have really staked a claim to this topic, we've done it now a couple years in a row, is because it really resonates with all of us, which is that we spend too much time on chronic disease management in the United States and not enough on prevention. And so a lot of what we'll talk about tonight is how do we prevent disease from occurring or getting worse, right? Because we spend far too much money on once disease has already established itself as, sort of heading towards an inevitable bad pathway. What can we do to help prevent that? How can we change our diet? How can we change what, our mind and how it interacts with our gut? All these things can help prevent chronic disease from developing. And so that's why we really like these topics, because we can tell you what we can do to be proactive, not reactive. And there's a lot of treatments in pancreatic disease. Many of them, you have taken some of these depending on what pancreas issue you may have come across. But a lot of these on the left-hand side are really important and don't get enough attention in your clinic visits, like diet, exercise, weight loss, and what we can do in terms of lifestyle habits. But a lot of these things on the right that many of our panelists are experts in, including endoscopic and surgical therapies, are important, but we just don't emphasize the other stuff enough sometimes in our clinical visits. So what's the goal of the NPF lecture? It's, understand all options to prevent and manage pancreas disease, and it's to deliver education to help promote self-advocacy. So a quick aside before we move on to tonight's talks. You'll probably gotten many emails from the NPF, but for those of you who are able to come, there will be a gala or a gala, I'm not sure still which one it is, on October 15th at the Palmer House Hilton. I think many of our members on the panel will be there. So obviously, if you're like us, interested in helping support research and advocacy for pancreas disease, this would be a great event for you to be at. So finally, getting to what you all came for, this evening's talks. I think you've seen the agenda, but we have a great set of speakers and talks. Diet in the Pancreas, Separating Fad from Fact, from Beth Dorfor from Northwestern Medicine. Smoking and Alcohol in Pancreas Disease, Is There a Safe Amount? With Melissa Hogg from North Shore University Health System. Managing the Psychological Impact of Pancreas Disease with Dawn Epstein, who just recently joined us at Northwestern Medicine. And then finally, Pancreas Insufficiency, Making the Diagnosis and Managing the Symptoms with Ajay Singh from Rush University. And then we will have time for questions and answers at the end. But what I would ask is that you use the Q&A at the bottom so that we can catalog them. And if it's an easy question, I will try to just answer it real time. But for the other questions, we'll save them to the end so the panel can discuss options. And so with that, I'm going to ask Beth to join us, and I'm going to stop sharing my screen to allow her to share her screen and her wisdom.
Wonderful. Thank you. Thank you, everyone, for spending your night with us, and thank you for the invitation. I'm thrilled to be here. What Dr. Keswani and I were talking a little bit about some of the topics that we could cover tonight because, our patients bring us so many smart questions. What should I eat? What supplements should I take? Do I need a probiotic? So we tried to focus not only on what we think our patients would find helpful in terms of chronic disease prevention, but also, many of our patients talk about an anti-inflammatory diet, and we wanted to highlight some of the things that we want you eating to have that anti-inflammatory benefit. And we'll also talk a little bit about supplements tonight. So, with that, these are our kind of key things we're going to touch on. I do want to say that, I work in our Digestive Health Center with Dr. Keswani, so I'm going to be talking a little bit about the topics that I thought would be good for you as patients and for your extended family to know about. But I'm really comfortable answering other questions as well about nutrition, enteral nutrition. Sometimes people have to go on enzyme therapy. So don't be afraid to ask a nutrition question that maybe isn't directly related to what we covered tonight. I'm happy to kind of collaborate with everyone to tackle those important questions. So these are some of the questions that my patients ask me most often. They'll say, Beth, I really want to do an anti-inflammatory diet. What types of food should I be eating? And conversely, what types of food should I not be eating? We also like to look at your nutritional wellness in general. Are you getting enough nutrients? Do you get enough protein? Have you lost weight? And we'll highlight some things you can look at that you might want to talk with your doctor about. We'll weave in a little discussion about supplements that is not incredibly comprehensive, but some rising stars, and happy to answer any other questions there. And then, of course, ultimately get to the nuts and bolts, which is what should you be eating more of? So first, we've got to take a look at the American diet. And if we look at pancreatic health, what we see is that our dietary pattern, not just one or two specific foods, but really our whole diet pattern really influences our risk of chronic disease. There are some foods that we consider a little bit more pro-inflammatory, like a lot of sugar, alcohol, a lot of red meat, smoked meats like hot dogs and bacon, and then foods that we consider to be anti-inflammatory, like fruits and vegetables. And we'll go into that in greater detail. Nutrition researchers like to use this healthy eating index as a way to kind of give an index variable to diet so that we can gauge, well, how healthy are people eating when they're in their 20s or 30s or 50s? And 100% would be the ideal diet. We don't expect people to be there, nor do we want you there, then you'd be working too hard to be too perfect. But for decades, what we see is the healthy eating index of the average American is just below 60%. So there's lots of public health opportunity for us to be doing a little bit better. And I want to give you some skills and tips to improve your own diet quality score. If we dissect this a little bit more and we look at carbohydrates, just to kind of explain what's going on here in this slide, the blue lines in the middle are kind of what's recommended in terms of how many grains we should be eating. And the orange dots on the top are really what we're eating. And we're talking about refined grains. So things like donuts and pastries, also like crackers and things that really turn to sugar pretty quickly. And it's okay to have some of those foods, but we really want at least half of the grains that we're eating to be more whole grains. And we'll kind of identify what those are. If we look at another sort of problem food for the pancreas and for Americans in general, it's sugar. We're eating more sugar than we did. In fact, American women in particular are getting a lot more calories than we did decades ago, primarily from sugar-sweetened beverages. I also want to point out that little red sliver there, that 1% in our diet that comes from fruit and fruit juice. So when we look at our diet, and often I'm encouraging my patients to eat a little bit more fruit, naturally, of course, our patients ask, well, I've been concerned to eat more fruit in my diet because I'm concerned about the fruit. That's not the type of sugar that we're worried about. We're really worried about added sugar in the diet. And as you can see, as Americans, we've got a little room for improvement. And the other kind of pro-inflammatory food that I really want to highlight before we get to the good stuff of what you should be eating has to do with saturated fats in the diet. So saturated fats are things like butter, cream, fried foods, bacon. And these are things that are not very good for our pancreas, and they're definitely not good for our blood vessels. In fact, when it comes to cardiovascular disease, if we could replace all of our saturated fats, or a good percentage of our saturated fats, with plant-based fats like vegetable oils and avocado and nut butters, and we'll talk a little bit more about that, it would have a substantial decreased risk of cardiovascular disease and potentially cancers as well. So this has been a really big push. And I work on this a lot with my patients, is not that you have to be vegan, but let's start seeing where we can swap some plant-based fats for some of those animal-based fats. And as you see, things like burgers and sandwiches and snack foods, those really are the biggest source of fat in the diet. I also want to say that many years ago, when we had patients with pancreatitis, if they were flaring or having pain, we would sometimes put people on very, very low fat diets. And what we found is that we really undercut their nutrition. So we try not to be too punishingly low fat with our patients. We really try more so to kind of change the fat in your diet, have it be more kind of healthy plant-based fat. And then if we need to, we'll use some enzyme therapy to help you tolerate the fats in your diet. Another hot topic that our patients often ask about are probiotics and whether or not they need probiotics. Well, the data on that for pancreatic health is still a little mixed, but what we do know is that our gut bacteria seems to be impacted negatively by certain foods in the diet. And in a few slides from now, I'll show you some things that actually can improve the state of your gut bugs or your gut bacteria. And the reason why we care about gut bacteria is we're finding that certain types of gut bacteria are very anti-inflammatory, and they can secrete certain compounds that can act like local analgesics and also may help our bodies and our immune systems in other ways. So these are things that if you see them on the label, try to pick another food: polysorbate 80, carrageenan, maltodextrin, CMC, also known as carboxymethylcellulose. I mean, when you look at this stuff, you think, well, gosh, I wouldn't really want to eat that either, but you'd be surprised how often you find it in ice creams and deli meats and snack foods. And this doesn't mean you have to eat organic, but you're looking for things without foods or ingredients that you can't necessarily pronounce. So what's the answer? Then if we want to eat more anti-inflammatory, we know we've got to look at some emulsifiers or things that are added into foods that can kind of destroy some of our good gut bacteria. But there's also things that we actively need to be adding into our diet, and that is more plants. So tonight, one of the things I really want to leave you with are some goals on how to layer in more whole grains, more nuts, more produce, because plants are very anti-inflammatory. And we're going to talk about why that is. But if we take your plate and we sort of try to redistribute it, for most Americans, now obviously this is going to maybe need to be personalized depending if you're a patient who has lost weight or has higher calorie needs. But what we're shooting for everyone in terms of prevention and wellness is a plate that is 2/3 plants. Now notice I'm using the term plants because plants are beans and lentils, they're fruits and vegetables, they're nuts and seeds, and they're whole grains. And whole grains, by the way, don't just have to be wheat. If you're a person that doesn't eat wheat, you can eat other whole grains like oats, quinoa, brown rice, corn masa, which is often used in corn tortilla and cornmeal. Those count as whole grains. And what we mean by whole grain is basically that it's been minimally processed. It sort of has to cook for longer before it's ready to eat. But these are all the different kinds of plants, and they provide antioxidants and lots of great nutrients, which we'll look at in a minute, that can have potent cancer-fighting effects. And very importantly, in the case of acute pancreatitis, may help to decrease the inflammatory response on the part of the body. One of the most interesting areas of research, in my opinion, related to diet and more plants, has been this collaboration of researchers called the American Gut Project. And the idea here is to see how we can kind of improve our gut bacteria and some of the anti-inflammatory compounds there by what we eat. So going back to that original kind of dilemma of whether or not you need a probiotic, I would argue that what you eat might be a better way to kind of grow more good anti-inflammatory types of gut bacteria than taking a probiotic pill. What researchers found is that people who had 30 or more different types of plants in a week had the most diverse anti-inflammatory types of bacteria, and they had the most abundant types. 30 plus sounds like a lot, but when you think about 7 days in a week, that's 5 different things in the course of the day. So maybe you have whole grain oatmeal at breakfast and you can layer on some nuts and fruit. Maybe at dinner, you're adding in a vegetable and a fruit, and maybe somewhere in lunch, you are also adding in nuts or beans, and you're there, you've hit your total. The other thing I want to highlight is, we spend a lot of time in our society focusing on, eating blueberries or eating kale. And what I want to highlight is that all fruits and vegetables have some very important anti-inflammatory compounds to them. Things that are red in color, yellow, orange, green, these are things that contain what we call phytonutrients. And phytonutrients are potent cancer-fighting agents. The other thing about them is there is a lot of research right now in acute pancreatitis and in other kind of inflammatory conditions to see how some of these compounds might act like a phytomedicine or a plant-based medicine to kind of reduce the impact of inflammation. I will tell you that pill versions of these don't seem to work as well as food versions, and that's probably because When food gets digested, it kind of feeds our good gut bacteria, and we seem to get other health benefits from that. So I also want to spend some time talking a little bit about, kind of a healthy diet on a budget. And by the way, we'll make these slides available to you. I was talking with everyone ahead of time that we'll put these in PDF form and send them to you, so you'll have these tips and tricks available. So here's my kind of what to eat checklist based on some of these plant-based foods that we just talked about. And I also want to highlight a few pantry staples. Pasta gets sort of a bad reputation, I think, undeservingly. People make it seem like it's a quick, refined sugar, but pasta actually can be a very low sugar food if you do the right portion and if you add other good things to it. When you add protein and when you add vegetables, you sort of drop the glycemic index, or you drop how quickly it converts to sugar in the bloodstream. I also want to kind of highlight, we know that fish and lean beef and poultry, that these are great, lean, healthy proteins and help you retain your muscle mass. But plant-based proteins are an excellent way for you to get fiber, phytonutrients, and also lots of protein. I have eggs in here as well. I know those aren't plant-based, but I do want to call out that one egg has about 7 grams of protein. So it can be an easy way for people to accumulate protein as the day goes on. I'm a big fan of trying to meal assemble, so kind of cook something once, eat it twice. So if you're going to make a chicken vegetable soup, intentionally try to put extra chicken in there so you can sort of recycle it for the next day and turn it into a salad or a taco when you're maybe feeling more fatigued. And happy to kind of share more meal planning ideas, but think about something that you could cook one night and recycle it the next. I also really like people to try to eat real food at snack time over snack food for a couple of reasons. One, it helps you get those phytonutrients in and more fiber. The other reason is that these real foods often are a great source of protein, and snack foods that are sort of engineered to be snack foods are also rich in a lot of those emulsifiers that we learned about early on. If you are diabetic, of course, the fiber here helps us regulate our blood sugar profiles. Grazing can be a helpful way for people to add more calories, but it can also result in weight gain. If you are a person that needs to maintain your weight, one of the best things you can do is schedule meal and snack times to prevent mindless eating. I'm going to kind of jump over some of these shortcuts to kind of increase your fruit and vegetable intake, since we'll send this out to all of you. But I do want to highlight, if you are a person who has lost weight, or you are concerned about your nutritional wellness, one marker that we like to use is a weight loss of more than 5 to 10% of your body weight in greater than 3 months is a good clue to us that either we need to up your calories or we need to kind of take a look at your absorption. So if you haven't seen your doctor in a little while and you've had unintentional weight loss like this, and you've got some of these nutrition impact symptoms here, it's time to talk about or open up that conversation with one of your healthcare providers. And here's some strategies if you need more calories. I think one thing I want to highlight is people get full early, and when they're tired, it's hard to eat a meal. If you have a protein shake that you like, whether it's pre-made or homemade, you can take a little shot of it with meals and accumulate the calories and the nutrition as the day goes on. So in summary, we want to always try to layer in more plant-based things. When you do that, it sort of boxes out some of the sugar and the animal products that we're trying to limit. In terms of supplements, although we can do a good multivitamin, we also I want you to start thinking about the colors in your food as an important source of supplementation. And then with your protein, start to try to experiment to get more plant-based proteins in. Ideally, 50% of your proteins should come from plants. And this will have a powerful anti-inflammatory effect for your diet. So with that, I will stop sharing my screen and pass that over to Dr. Keswani to introduce our next speaker.
Thank you, Beth. It's always amazing to learn from you and also feel guilty about what I'm doing. So it's good to be reinvigorated about my rest of my week's meal plan. So I have the distinct pleasure to invite Dr. Melissa Hogg to speak to us, and I've given her a tough topic as well, which is my favorite thing to do. Is there a safe amount for smoking and alcohol? Thanks, Melissa.
All right. Hello. Hopefully you could hear me okay. I'm Melissa. I'm a surgeon, cancer surgery by training. I'm at North Shore, and I'm going to be talking about something I talk to patients about all the time, but I've never actually given a formal talk about, and that is smoking and alcohol. Is there a safe amount? I have disclosures for robotic surgery. So today we're going to talk a little bit about creating a balance, and is that something we can do as it pertains to like tobacco and alcohol? And I wish I was giving you a lot of positive pro tips like our last speaker, but I feel like I'm like the Debbie Downer of the group today. But tobacco is a very interesting product, and I mean, I think we've come a long way both in advertising and our doctor profession in terms of endorsing cigarettes here, where, more doctors smoke Camels than any other cigarette. And, if you can't trust a doctor, I mean, who can you trust more than Santa, smoking his Pall Malls? But, a lot of these types of myths have really gone by the wayside in the last few decades, but really more rampant is what we're seeing in terms of alcohol and the appeal, both from the old times with Sean Connery, up to current times with Snoop Dogg. And not only are people really, promoting and advertising alcohol, but you see a lot of celebrities now with their own alcohol labels, even, notable, super, fit, super healthy, The Rock, guzzling tequila right here. So what are patients and doctors to do to kind of combat this sort of appeal? So as Dr. Keswani mentioned earlier, there's a lot of pancreatic considerations out there. And that's one of the joys of the National Pancreas Foundation, sort of honing in on all kinds of different pancreatic pathologies, and not just one. And so we're going to sort of talk about tobacco and alcohol in these different regions as well, and sort of going to start by talking about pancreatic cysts. So I see a ton of pancreatic cysts. I think I give these statistics to patients all the time that, over 6 million new pancreatic cysts are found each year because people are getting scans for appendicitis, they're getting scans for kidney stones, you name it. And the pancreas is seen, and, so these little cysts can be seen as well. And of these 6 million cysts, about half of those are mucinous cysts. And these are important because mucinous cysts do have some sort of malignant potential. But that's tempered with the fact that really only about 8,000 mucinous cysts become pancreas cancers each year. I tell people about 15% of pancreas cancers are usually from this mucinous cyst pathway. So a lot of the focus, that I have in terms of pancreatic cysts are talking about surveillance. When do we operate? We talk about the Sendai criteria, then the Fukuyama criteria and the AGA guidelines. And any of you with pancreas cysts out there, may have people that follow your cysts and show all these different guidelines. But, I really put this busy slide up here not to talk about the guidelines per se, but that there's a lot of touch points for doctors in pancreas cysts. You have surgeons, you have endoscopists, primary care doctors, et cetera. And this is a lot of year after year or every other year or every 3 to 6 months, depending on your cyst. So a lot of repeated customer contact. So it's a lot of time that we have to discuss and counsel with patients. And so I get asked all the time with people with pancreas cysts, can you aspirate them and they go away? Is there a medicine I could take to make them go away? Can't you just take them out because I don't want to develop cancer, et cetera? And honestly, there's really no data for lifestyle modifications for people with pancreas cysts. So, I don't tell people that see me for pancreas cysts that they have to not smoke and, have to not drink, but at the same time, I'm not really advertising them to go crazy with these different things and really sort of beat any records for tobacco and alcohol. But I think, if you're out there with a pancreas cyst, there's not really a ton of data saying that there is anything that you have to do to change this. So next, moving on, is sort of the high-risk pancreas cancer conditions. So, I tell people, that ask, why did I get pancreas cancer? I say, mostly it's bad luck, but, 10% of the time we can see hereditary causes, which are known genetic syndromes with a known germline mutation, increasing their risk. or people with familial pancreas cancer that have 2 first-degree relatives or 3 non-first-degree relatives with pancreas cancer. And really, mostly these people probably have some sort of germline mutation that we just haven't recognized yet. But a good percentage, maybe about 70%, are just sporadic. They developed it because a cell went awry. And so these are a bunch of different hereditary pancreatic syndromes that increase your risk. And most notably, BRCA1 and BRCA2 are probably the most common of the ones we see. And this is another touch point for gastroenterologists, surgeons, et cetera. This is sort of older data looking at the MRIs from the NCCN and endoscopic ultrasounds recommended every 1 to 2 years. And this has actually been updated in the last couple of years with specific guidelines that I'm going to go through. But this is just to point out that this group of individuals is at high risk already for pancreas cancer. So when we look at sporadic risk factors that can be additive to your risk of pancreas cancer in a group that already has them, smoking increases the risk by about 2 to 3-fold for getting pancreas cancer. We also see chronic pancreatitis as a 6 times the increased risk of pancreas cancer. In fact, I do survey a lot of people with chronic pancreatitis in my high-risk clinic because of this risk. And these scans could be very difficult to determine masses versus calcification, et cetera. So alcohol may contribute to pancreas cancer as well. And the exact mechanism is somewhat unknown. One thought is through chronic pancreatitis, which increases your risk. Another is through obesity and inflammation. And also through a synergistic effect with tobacco. So the American Cancer Society actually recommends that it's best to just not drink alcohol. But should you choose to drink alcohol, that's no more than 1 drink a day for women or 2 drinks a day for men for trying to temporize this risk of pancreatic cancer. So I would say, as opposed to pancreas cysts where there's no data, I would say for this, there's okay data for lifestyle modifications for people with high risk pancreatic cancer syndromes. And that's not to smoke and to really kind of go light with alcohol, maybe not necessarily avoid it altogether, but to proceed with caution. So next is pancreas cancer. So pancreas cancer, can present in a metastatic setting half the time where it's already spread, or in these different settings where we're either considered resectable, borderline, or unresectable, really based on blood vessels that the pancreas wraps around. So resectable, really minimal contact with blood vessels. Borderline could have a lot of vein contact, but really minimal arterial contact. But unresectable usually means we can't take it out because there's just extensive blood vessel involvement. So this is just to say that people with pancreas cancer that have all different varieties of presentations and may undergo all kinds of different varieties of therapy, from surgery to chemotherapy to radiation. And this is, from PanCan talking about smoking and pancreas cancer. And interestingly, not only does not only does tobacco increase the risk of pancreas cancer, but it also increases individuals' risk of dying from the disease. And this actually shows that the more you smoke, the longer you smoke, the worse survival there is for pancreas cancer. And that actually quitting, at any time can improve your survival over time. So it's never too late to quit smoking, in other words. And so, I think probably most hospitals have, tobacco cessation programs. And really we urge anyone that has cancer and smokes to really stop smoking. And just even in general, as surgeons, anyone that we're operating on, we urge them to stop smoking. In fact, I saw a woman yesterday with a neuroendocrine tumor, and these you don't have to act on as quickly as pancreas cancers. And so I put her through a smoking cessation program before we scheduled her surgery. But also it's important to think that alcohol can interact with other treatment. So for chemotherapy, both chemo and alcohol are harmful to the liver, causing sinusoidal congestion and other things. Many symptoms from chemotherapy can be worsened with alcohol, and there are medications that interact. And in terms of surgery, alcohol does not mix well with pain medication. Fatty liver contributes to surgical complication, and wound healing is affected extensively by tobacco, but also by alcohol. So you have to worry about, when you have cancer, what treatments you're undergoing, and how these adjuncts of tobacco and alcohol could both affect the biology of your cancer, but also affect your therapy. So there is pretty good data, for lifestyle modifications, and really don't smoke, don't drink if you have pancreas cancer. So lastly, I'm going to touch on pancreatitis. And, pancreatitis, I did not break this down into acute and chronic pancreatitis, but obviously they're quite different diseases. But I would say in terms of the effect of smoking and the effect of alcohol on sort of disease biology of the pancreas, the pancreatitis would definitely be the ugly in this scenario, where essentially the short answer of the talk is I tell almost everyone with pancreatitis, don't drink, don't smoke, really watch your diet. But we'll kind of delve into that a little bit further. And, people that get acute pancreatitis, and this can happen especially from binging large amounts of sort of hard liquor, and you could get necrosis. And that's what we're seeing here, where the pancreas should be. A lot of this is necrotic. There's some air in it, some infected necrosis. And so I'm going to give a little disclaimer for any queasy people out there, any people eating, that I'm going to show you a surgical video here. It's sort of hard for surgeons to give epidemiology talks because most of our stuff is technical and outcomes based. But this is an example of a robotic cystgastrostomy for infected necrosis. And you see here going through the anterior wall of the stomach and then through the posterior wall of the stomach in order to get to that pancreas fluid collection and necroma. And here you see just a lot of fluid and edema from the acute pancreatitis. And this, can be done endoscopically as well. And there are different parameters for when we do this surgically, but I would say probably 80% of what we do is send these to endoscopists for endoscopic removal. But then here's a, example of a pretty extensive necroma that's debrided. And a lot of times people are like, I don't understand why I'm pancreas insufficient. I don't really understand, why I'm diabetic now. And, it's really kind of hard to explain that, a lot of times with some of these acute pancreatitis, you get necrosis of the pancreas, where this is basically what the pancreas used to be. And it's a lot of just dead tissue. And this is sort of how we'll have to remove it. You don't always have to remove that. There's just some certain circumstances. And really surgery is very rare for both acute and chronic pancreatitis. So I know Dr. Keswani went a little bit through the anatomy of the pancreas earlier, so I won't have to repeat any of that. But in terms of the process which leads to why alcohol can cause pancreatitis, is that where these, ducts secrete pancreatic juice, that the viscosity of these can increase with alcohol use. And with this increase of viscosity, it can plug these ducts and make calcifications. And when these ducts get plugged, there's a backup that can lead to sort of inflammation, but then also fibrosis of the gland that can't empty out. And then this eventually leads to cell death and loss of these both islet, acinar, and ductal cells, which diminish the function of the pancreas. And sort of the unfortunate reality is about 40 to 50% of acute pancreatitis is from alcohol, and about 70 to 80% of chronic pancreatitis is from alcohol. So really avoidance of alcohol when you're in these scenarios is of the utmost importance. And so in terms of the mechanism of tobacco, I was looking this up for this talk, and, there is some very long pathways, starting from nicotine and leading, down some pathways, which were even a little bit beyond what I could understand. But I think, what we learned from just population-based studies, looking at nursing groups, looking at VA patients, all kinds of other large, population-based where they, watch about 30,000 patients, is that what they found were people that drank alcohol were 3.65 times more likely to develop acute pancreatitis Those who smoked were about 1.6 times more likely. But these effects were synergistic. So if you were a smoker and a drinker, these were higher than being a non-smoker and a non-drinker. So really, there's great data, so it kind of went from like no data, okay data, good data, and great data for lifestyle modifications with tobacco. So just really don't smoke, you might croak. And then alcohol and, really most alcohol, but then also a lot more linked to hard alcohol than and excessive amounts of alcohol than just, a beer and a wine. But I do tell patients that, not all the fun is gone, that they can, still have sex and listen to rock and roll, but to try and cut out tobacco and alcohol. And that's the end of my talk. Thank you for your attention.
Thanks, Melissa, and thank you for tackling a difficult topic, which is, full of, as you said, mostly negative news to patients, what to avoid, but I'm glad you kept a positive spin on everything. And to keep us continuing in that positive direction, it's my pleasure to welcome another colleague from Northwestern Medicine, Dawn Epstein, and she's going to be talking about managing the psychological impact of pancreas disease, which I think is just a wonderful thing to think about. And I think if you're someone who doesn't live with pancreas disease and is a family member or friend, a lot of these techniques can be translated just to everything else that you do in your daily life. So it's really an enriching talk for all of us. So thanks again, Dawn, for joining us.
Of course. Thank you so much for that wonderful introduction. And thank you to the folks at the National Pancreas Foundation for hosting tonight's event. I'm really grateful for the opportunity to speak with you all this evening on the topic of promoting wellness in pancreas disease. Before I dive in, I don't have anything to disclose, but I would like to acknowledge briefly Dr. Megan Petrick from the University of Minnesota Medical School, who shared some really helpful resources with me as I prepared for this evening's talk. As you know from your lived experience, the management of chronic pain, fatigue, and the additional psychosocial challenges associated with your condition can be quite taxing, both emotionally and physically. I will be presenting information tonight on some non-pharmacological interventions that can support overall health and well-being and increase your sense of agency and control. Pain is a hallmark feature of chronic pancreatitis and is highly prevalent in pancreatic cancer. Pain is typically the most troublesome symptom for individuals with pancreas disease and the one for which medical attention is most often sought. Pain in these conditions is frequently debilitating and consequently an important predictor of quality of life and disability. Chronic pain is multifactorial and often requires a multidisciplinary approach to treatment, particularly when some of those more conventional treatments fall short. One potentially useful way of understanding the complexity of chronic pain is to conceptualize it from the biopsychosocial perspective, which highlights the interplay between biological, psychological, and sociocultural and environmental factors. It acknowledges that pain is not only influenced by biomedical factors, but also one's thoughts, beliefs, expectations, and coping behaviors. Biological factors typically bring about pain, but over time, psychological and social factors can maintain or worsen pain intensity, adjustment to pain, and the experience of disability. The brain creates the experience of pain based on pain signals it receives from the body, combined with stress levels in the body, your emotional state, your thoughts, memories, beliefs, expectations, behaviors in response to pain, and what's going on around you. Cognitive factors appear to exert a particularly strong influence on the perception and response to pain. In fact, pain, stress, and emotions share many of the same pathways in the brain and interact to affect pain, turning the volume up or down on pain. High stress levels can promote muscle tension and release neurochemicals that turn the volume up on pain. A stressor can be condition-specific or completely unrelated. Pain itself is a stressor. Any stressor which poses a physical or psychological threat to safety, status, or well-being evokes a physiological stress response. A short-term stress response to pain or non-pain related stressors can be adaptive in the short term, initially serving to promote survival or to motivate success. However, frequent and persistent activation of that stress response, often triggered more often by a psychological threat or perception of pain, can worsen or prolong the pain experience, compromise immune function, and impact mood and cognition. Chronic pain is associated with depression, anxiety, fear, hyperarousal, catastrophic thinking, and avoidant coping. Indeed, individuals affected by persistent pain are 4 times more likely than their pain-free counterparts to experience clinical anxiety and depression. And these secondary pain manifestations further amplify pain. Patients with anxiety and/or depression are significantly more likely to report pain, more severe pain, and more pain interference. From the cognitive behavioral perspective, people with pain can have negative expectations about their ability to control life circumstances and behaviors because of their pain. Pain catastrophizing, which is a common unhelpful thinking pattern in chronic pain, is the tendency to both underestimate our ability to cope with adversity and overestimate the consequences and costs of adversity when it strikes. Pain catastrophizing has been strongly implicated in the intensification of pain and related problems. Worry, on the other hand, is often abstract and future-oriented. Its role is to control threatening information associated with pain, with attempts to problem solve. However, these attempts are usually not very fruitful, as the problems are typically hypothetical in nature and therefore unsolvable. Excessive worry brings about negative emotional states. It's associated with increased hypervigilance of body sensations and inflated threat-related beliefs and pain suffering. Cognitive appraisals have an effect on behavior, which can lead to reduced activity, which can contribute to things like isolation, magnification of emotional distress, and subsequent physical limitations. Being on guard or hyper alert for threatening information, again, might be adaptive and even critical for survival in the short term, but maintaining excessive focus on pain in the long term only functions to worsen pain and motivate avoidance and reduced activity. We know that avoidance has myriad negative consequences, including maintaining anxiety, but also worsening mood and overall health. It reduces access to natural reinforcers in our environment and can also result in things like deconditioning or nutritional deficiencies if we're avoiding things like movement or eating. So you can see how one's world can become quite small over time. Suffering stems from a lack of contact with the things that matter most, that we value. And avoiding to not feel ends up resulting in not living. We use a variety of interventions, cognitive, behavioral, mindfulness, and acceptance-based techniques to help individuals struggling with chronic illness and pain move in a more meaningful life direction, even in the context of disease-related barriers like pain and fatigue. It's certainly easier said than done, but honoring the dialectic of, I feel bad and I can do X, can help to expand your world, decrease suffering, and increase quality of life. So we've talked about a variety of factors that can impact our pain experience, and as you've probably gathered, those factors are interrelated. The cycle typically starts with some form of discomfort, often pain, which often leads to a thought that may be out of proportion with the current situation. Something like, I'm never going to feel better, which reliably leads to feeling upset, hopeless, frustrated, maybe even helpless, which then revs up our fight or flight response, which in turn amplifies our experience of pain. As we discussed earlier, these cognitive appraisals may also motivate avoidance of valued activities due to fear. So what can we do? Well, there's various points along the cycle where we can intervene. We can intervene by modifying arousal or addressing that stress response using relaxation training. We can change the way we're thinking about our symptoms, our condition, and the future using techniques such as cognitive restructuring or cognitive diffusion. And we can reduce avoidant behaviors and increase engagement in valued activity. Modification of arousal can be achieved using various techniques, including diaphragmatic breathing, progressive muscle relaxation, and visual imagery. Diaphragmatic breathing, also called abdominal breathing or belly breathing, is an empirically based self-regulation technique that's relatively simple, quick, and portable. It involves contraction of the diaphragm, expansion of the belly, and deepening of the inhalation and exhalation. Diaphragmatic breathing activates the parasympathetic nervous system, that part of the nervous system that functions as the brake for our body's stress response, and helps us to reduce the impact of the stress response on the body. It also helps to reduce hypervigilance to symptoms. It assists in management of pain and discomfort, and it promotes digestion. Progressive muscle relaxation is the systematic tensing and relaxing of major muscle groups throughout the body to trigger physical relaxation. Over time, it can also help you to identify muscle tension in the body and employ targeted relaxation for relief. And then guided visual imagery is the application of healing visualization, often nature imagery, to induce a relaxation response in the body, shift attention away from pain and discomfort, and boost overall well-being. Cognitive techniques directly target maladaptive cognitions and cognitive processes to manage or control pain. We can address pain, catastrophizing, and excessive worry with a technique called cognitive restructuring. If you're having a lot of those what-if, future-oriented, hypothetical worries, you can use these questions to support the development of a more balanced, objective way of thinking. Asking yourself, what is the evidence for and against this thought? Am I engaging in a little bit of confirmation bias, only attending to the data that really confirms my fears and sort of neglecting everything else? Am I confusing probability with possibility? And if you're engaging in that catastrophic thinking, I might guide you to ask questions like, is this discomfort time limited? Is it manageable? Can I let go? How useful is it for me to have this thought? And what if worst case scenario does happen? Can I cope? So an example of a more adaptive counter thought might be, I'm experiencing throbbing pain. I don't like it, I don't want it, but I have experienced this before and I know how to manage it. I know that I can manage it. It can also be helpful to kind of shift your perspective. So you can ask yourself a question like, what might I tell a friend or a loved one if they were dealing with a similar problem? We tend to be much better at giving balanced, objective, kind feedback to others, not so good about doing that for ourselves. So sometimes that question can be quite helpful. And then if it's too difficult to modify your thinking because you just can't argue against the thought, or maybe you can argue against it, but you're just not in the position in the moment to really believe it, you can take a slightly different approach. This approach has you, look at your thoughts as naturally occurring private events with no effort to change them, but rather to create a little bit of distance from them, to become unhooked by or unfused with them, to look at your thoughts rather than from your thoughts, to observe and describe and reflect but not react, being curious and without judgment. So the thought, I am never going to feel better, becomes, I am having the thought that I am never going to feel better. Or even better, I am noticing that I'm having the thought, I am never going to feel better. This creates a little bit of that sense of separation and distance from the thought, giving you space to decide how you want to move forward, and allows you to be more reflective, less reactive, and supports the ability to cope more adaptively. To address avoidance, we can challenge threat-based cognitive appraisals by developing behavioral experiments aimed at gradually increasing contact with feared situations and testing out these fear-based assumptions. This can improve willingness to engage in activity, reduce anxiety, and contribute to beliefs about competence and self-efficacy. I also highlighted the importance of increasing engagement in pleasurable and important activities for mood and quality of life. It's important to align our behaviors with our values and long-term goals because A, we'll get more out of them, but B, we also want to be thoughtful about where we're putting our energy and efforts, knowing that energy is often a limited resource. Activity pacing can assist with the practical management of pain and fatigue, aiming to do a similar amount of activity on both good and bad pain days. On setting activity goals in advance that are informed by your values will help reduce this boom-bust overactivity, underactivity pattern we often see in chronic pain. As I conclude my talk today, I want to stress the notion, as hard as it is to accept and as much as we want to struggle against this, that pain is inevitable. Whether it's pain associated with our condition, emotional or physical pain, or something else, pain will show up over and over again in different forms and often at inopportune times. Suffering, however, is that tension we create around pain that results from resistance and avoidance and that persistent struggle against unpleasant sensations and feelings. Be mindful of this. Notice the differences between the physical sensations of pain and your reactions to them, as well as the effects that these reactions have on your mental health and overall functioning. Emotional pain arises from this mismatch or gap between the desired reality and your current reality. Respond to pain with acceptance and self-compassion. Reconnect to values and set goals in service of those values, keeping in mind the limitations you might face. Action can bring some discomfort, but discomfort often accompanies opportunities for meaningful engagement and personal growth. Giving up the struggle against direct control over pain, coupled with a decision to focus on the things you value most in life, will allow you to avoid the unfortunate but incredibly common experience of pain on top of pain. So consider what you can do today in support of this goal, even if it seems a little bit trivial, and get back to living. Thank you very much.
Thank you, Dawn. I appreciate you walking us through that and helping us think about what we can do as well proactively. So again, very much appreciated. Now I'm going to turn to our final talk of the night. Dr. Rajesh Singh is a friend at Rush who's going to talk about making the diagnosis of pancreas insufficiency and what we can do about it. We see a lot of commercials on it, and we also know we see it through diseases we manage. So very important for us to understand what we need to do to help make progress in this area. Ajay, please go ahead.
Thanks a lot, Dr. Keswani, for the introduction. I would like to thank NPF for organizing this wonderful event, and I'm honored to be here along with my colleagues from Chicagoland area who work very closely with patients with pancreatic disorders. I think we are running a little short on time, but I'll try to be very brief and succinct when we talk about pancreatic insufficiency. How do we make the diagnosis and treat the symptoms? These are my disclosures. So at least here we can all agree pancreas is the most important organ in the body. It's around 12 to 15 centimeter fatty organ right behind your stomach, more towards the center and towards the left side of the body. Your pancreas has two main types of cells. One are the cells called the islet cells, which secrete insulin and glucagon, and these go into the bloodstream and help control your blood sugar levels. And then there's second kind of cells called the Isner cells, or the cells that secrete these molecules called enzymes, which are secreted through the small duct called the pancreatic duct into the intestine, and these enzymes go into your intestine and help you digest fat, carbohydrates, and proteins that we consume in the food, and also help absorb some of the vitamins which need fats to be emulsified and to be absorbed. So now, in patients with chronic pancreatitis, what happens is that there is persistent inflammation in the pancreatic tissue, which eventually leads to fibrosis or scarring of the tissue, and these cells are eventually damaged, destroyed, and replaced by scar tissue. Hence, there is decreased production of insulin and glucagon that goes in the bloodstream, so blood sugar levels are not well controlled, and patients develop diabetes. The other thing that happens is that the enzymes that are supposed to go through the duct into the intestine are also not produced. So decreased production of pancreatic enzymes, the lipase, amylase, proteases, not enough going into the intestine, and hence the fats, carbohydrate, proteins, and fat-soluble vitamins that we consume in our diet are not properly absorbed. And that is what we call exocrine pancreatic insufficiency. So as we can see that the most common cause of exocrine pancreatic insufficiency we see is destruction of these cells, which can happen in patients with chronic pancreatitis or in patients with acute pancreatitis. But then there are other causes that can also cause exocrine pancreatic insufficiency. Patients, your pancreas needs some signals from your stomach, from your intestine, to which signal it that the food is there and you need to start secreting these enzymes. And those signals can be impaired or not very helpful in patients who undergo surgeries, like surgery on the stomach, or in patients who have diseases of the small bowel, like patients with celiac disease or Crohn's disease. Those signals to the pancreas are not there. Or sometimes the duct of the pancreas can be obstructed, even though the cells are working fine. And then even though the cells are producing those enzymes, they never make their way to the intestine, as we see in patients with pancreatic cancer, cystic fibrosis. And sometimes patients with diabetes also have pancreatic insufficiency, the etiology of which is a little unclear. One important thing I would like to stress is that patients need to lose at least 90% of their functioning pancreatic cells to develop symptoms of exocrine pancreatic insufficiency. So a lot of patients we see in the clinic have chronic pancreatitis, but they still have enough function so that they do not develop pancreatic insufficiency. We usually believe that it takes up to at least 5 years after you develop chronic pancreatitis to develop symptoms of pancreatic exocrine insufficiency. And again, since it's kind of a spectrum when you start losing cells and get to that stage, the symptoms can be very variable. In the early stages where you are just at the cusp where you're around 90% or even earlier than that, most of the patients are asymptomatic. But as the amount of enzymes keep going down, patients start developing the inability to digest the fats, the proteins, and the carbohydrates in their food. And as these products are not absorbed, they go down into the intestine and the bacteria work on them, producing gases which cause cramping, bloating, abdominal pain, flatulence. And then as these unabsorbed components of the diet pass out in the stool, patients develop what we call steatorrhea, that is loose, greasy stools, which patients describe are sticky to the bowl and are difficult to flush. What are the consequences of these food elements not being absorbed is patients start having weight loss, they lose their appetite, and eventually with the vitamins and the minerals not being absorbed, patients start having bone diseases, osteoporosis, bone fractures are common in our problems, vision problems, and patients lose muscle mass. And then all of this can lead to fatigue. And, and a lot of patients just come with very non-specific complaints. As we can see, it is where the symptoms of exocrine pancreatic insufficiency are very variable, as are the reasons patients can get it. Making a diagnosis can be very challenging. The most important thing when we need is the right clinical setting. And some patients on whom we know have severe pancreatitis and have severe exocrine pancreatic insufficiency, the diagnosis can be very easy. But again, in patients where the diagnosis is not very clear, what I am looking for when I see patients in the clinic is this patient at risk for EPI or pancreatic insufficiency? Do they have risk factors for pancreatic disease? They had surgeries on their intestine or surgeries on their pancreas in the past? Or do patients have small bowel disease like Crohn's disease or celiac disease that can cause exocrine pancreatic insufficiency? Most of the patients who usually come to see us for exocrine pancreatic insufficiency usually have some sort of imaging done. Something in severe disease, something as simple as an X-ray can be beneficial, but in most of the patients, we need to get a CT scan or an MRI to look at the pancreas, how the duct is, and how much the enzymes pancreas is secreting can also be checked by doing a special MRI called a secretin MRI, where we inject some substance to cause your pancreas to secrete enzymes and see if it shows up on the MRI. A lot of times, the damage to the pancreas or the scarring is so subtle that it cannot be picked up on any of the imaging tests. And in those situations, we do this procedure called endoscopic ultrasound. We are under sedation with a camera scope from the mouth. The camera scope has an ultrasound. We do ultrasound of the pancreas from your stomach and get finer detailed images of the structure of the pancreas and how the pancreatic duct is behaving. And that gives us a very good idea about how much damage or scarring is in their pancreas. But again, damage or scarring in the pancreas seen on ultrasound or on the CTs or MRIs still does not translate to exocrine pancreatic insufficiency, because we don't know if we still want to confirm that you are not absorbing enough food and your pancreas is not making enough enzymes. So what's the best way to do it? The best way is, or the gold standard is that we put patients on 3 days of high fat diet, tell them to eat 100 grams of fat every day, then collect that stool for 3 days and bring it to the lab. I haven't done that in 6 years, 7 years I have been practiced, and I don't plan on doing that, and neither any of my patients would be interested in doing that. So what is an indirect way of checking? There is this enzyme called elastase, which your pancreas secretes in the intestine, and it is passed out in the stool relatively unchanged. So that is what we use. We check for what we call fecal elastase in the stool and see if the levels are low. That usually indicates patients the pancreas is not secreting enough enzymes and patients have exocrine pancreatic insufficiency. But again, everything comes with its caveats. Pancreas fecal elastase is a good test, but you do need to have a solid stool sample. If the patient is having diarrhea from other reasons like infection or Crohn's disease or ulcerative colitis or bacterial overgrowth, what would happen is that they are already having loose stool, and the pancreas is secreting the right amount of elastase, but as it is diluted with the diarrhea, on this test, it would look like you have low fecal elastase. And a lot of patients I see in my clinic have this low fecal elastase, but they do not fit the definition of exocrine pancreatic insufficiency. So that's why it's very important to use the right clinical setting, find the patients who really fit the profile that would cause pancreatic insufficiency or exocrine pancreatic insufficiency. So once we have an established diagnosis of EPI, then comes the treatment part. And the treatment is not, there is no one magic fix to this. This is a lifelong situation. and it really needs a real commitment from the patient and from the physician and the treating side, and long-term collaboration. I think there was a question about who to see once you have EPI and chronic pancreatitis. And there is no one physician who would be managing this. It's a team approach. Your primary care physician is usually the quarterback who kind of arranges all these follow-ups. But all patients with chronic pancreatitis should see a gastroenterologist, ideally someone who specializes in pancreatic disease, and an endocrinologist who can manage your diabetes and the bone loss and the osteoporosis that comes with it. And then depending on what symptoms are predominant, the gastroenterologist can make a decision if you need to go see a dietitian, if you need to go a pain specialist, and sometimes we have to get the surgeons involved for drainage procedures on the pancreas. So again, your primary care physician and your gastroenterologist should work very closely and coming up with a plan. Most of my patients I see do see an endocrinologist and a dietitian, and we have a good pain control team who we work with as well. Lifestyle changes, I think Beth and Dawn have talked a lot about it. We recommend healthy, normal diet. In the past, we used to say the patient should have a low-fat diet, but then that was leading to weight loss issues and insufficient weight gain. So now we see the healthy, normal diet is what we recommend in patients with chronic pancreatitis or exocrine pancreatic insufficiency. Dr. Hogg has talked about smoking cessation and alcohol cessation. Smoking does significantly increase your risk of pancreatic cancer, so it's a big no-no. And again, alcohol does cause further scarring and stone formation in the pancreas. So if you're having pain symptoms, those do not improve. So we work closely with our psychologists and our primary care physicians to come up with a plan for smoking and alcohol cessation. Again, pancreatic enzyme replacement. This is the most important part and the cornerstone for treating exocrine pancreatic insufficiency. The pancreatic enzymes have been available for more than 100 years, but they were only regulated around a decade ago by the FDA. There are different formulations available. Most of these are derived from pig pancreas. There are some research studies going on about some recombinant ones in patients who have allergies or for religious reasons do not want to take products, but they are not widely available in the market. Again, there is a way how to take it. There are different questions how to take it. Usually we tell the patients to take these enzymes with the first bite of your meal. But if you're going to be eating for more than 20 minutes, maybe half with the first bite, half in the middle of the meal. And then there are different kinds of formulations available. But again, there's a standard dose we start with and then adjust the dose according to the response. We do have all our patients work our endocrinology to make sure bone loss is not an issue. All patients we see should be on a daily multivitamin, especially calcium and vitamin D. And we do routine lab assessments. All patients should get DEXA scans or bone densitometry to make sure there's no osteoporosis. What do we do if we're doing all this and if things are working or not? There is no good way to know if things are working, but there is no labs or anything, but the patients themselves report within 4 to 6 weeks of starting these enzymes, they are feeling much better. The weight loss has stopped. The foul smelling loose stools have gotten better, and less fatigue, quality of life is much better. But again, these patients do need long-term close follow-up and monitoring, usually lifelong. What if things are not working? A lot of patients come, hey, I have been taking these enzymes for 6-8 weeks, but nothing is working. First thing is taking it incorrectly. Are you taking it the right way in the beginning of the meal or in the or the middle of the meal? The dose needs adjustment. Sometimes patients do need more dose than it is. Sometimes the stomach acid can be degrading the enzymes, so we can sometimes start patients on acid medications so that the enzymes are not degraded. Then the other question is there something else we are missing? Is there Crohn's disease? Is there celiac disease, bacterial overgrowth, other things that can mimic or worsen your exocrine pancreatic insufficiency that we need to work on? And then there's always one thing which is worse than chronic pancreatitis that we always worry. nothing is working, your patients are losing weight, because chronic pancreatitis does put you at increased risk for pancreatic cancer. Is that something we are dealing with? In which case, we would likely go for more imaging tests. Again, exocrine pancreatic insufficiency is common in chronic pancreatitis. The symptoms are very variable. You do need a team approach. There is no one person who can be managing all aspects of your pancreas care. And that treatment is also very involves lifestyle changes, involves pancreatic enzymes, and it can involve endoscopic procedures and surgery. And again, close lifelong follow-up is needed. Thank you.
Thank you so much. Appreciate it. If we could have our other speakers come, we'll take questions just for a few minutes. I know everyone's donated their time tonight, and obviously the audience. We didn't talk about sleep and pancreatic disease, but that is also important, so we don't want to keep you up too late. I'm going to start with a question for Dr. Hogg, but I'm going to prepare Beth Dorfler while I'm doing that. She answered a lot of great questions live, and maybe while I'm asking a question to Dr. Hogg, she could think about some of the questions that she got and what sort of additional pearls of wisdom she'd share based on those questions. But what's a quick question about marijuana? It sort of comes up a lot in my clinic, and how do you describe it? You talked a little bit in the Q&A about nicotine is bad in all forms. What is your take on marijuana, not on a personal level, but for our patients?
Yeah, I probably don't have extensive knowledge of it, but I haven't ever come across marijuana in a lot of aspects for pancreatitis or for pancreas cancer. In fact, we do actually advocate for the use of medical marijuana, in the setting of pancreas cancer, especially for like nausea, appetite stimulants, and pain. So, I haven't seen much data about not using it in those regards.
Yeah, I mean, that's what I've looked at and seen as well, is that marijuana is certainly not the same offender that tobacco and smoking is, and it is something that many patients are very concerned that when I say no smoking, that's something they have to give up. I don't have enough knowledge to advocate for it, but I don't have enough knowledge to tell them that it's going to be harmful for their disease. Ajay, did you have some different thought on that?
No, I agree. Only we have data is that there are some case reports where patients have had bad pancreatitis and no one could figure out the reason, and it was thought that marijuana could have contributed to it. But usually, especially in patients with pancreatic cancer, we don't know if it has the same harmful effect as smoking and alcohol.
I think in general, our palliative doctors, when people are kind of going down the road of the medicinal uses, do advocate of gummies over inhaled and smoked forms. So I think that those may overall be safer because of other stuff that may be added to the smoked forms, just as a note.
Perfect. All right, Beth, I put you on the spot, but I gave you a prep time for it. So
yeah. Prep time taken. Thank you. So one of the questions that someone had asked, which is an excellent question, is, some of these plant-based foods are sort of hard to tolerate at times if you have GI symptoms. And specifically, someone had asked about tolerating the fat in nuts and seeds, and then certain other vegetables like green vegetables. So I'd like to tackle the nuts and seeds. There's a couple of ways to think about this. One, as Dr. Singh had mentioned, if you want to eat peanut butter, almond butter, avocado, things that are kind of higher in fat, and you are taking enzymes, it's something that we can kind of discuss with your doctor is, are we taking them properly? Are you taking enough, to kind of cover the fat? Because we wouldn't want you to cut those plant-based fats out. We want to see how we can help you get away with it. The other thing that works against people sometimes is truly the fiber that are in those nuts. So if you can sort of pre-digest the fiber by pureeing it using a peanut butter or an almond butter, you're getting a lot of the same antioxidants, the healthy fats, the healthy calories. but you're sort of making that fiber pre-digested or easier to break through. And sort of the same thing applies to vegetables. Sometimes my patients say, if I eat a salad, it comes right through me. When you cook vegetables, you break down the fibers that are sometimes a little harder or more fermentable by the gut bacteria. You lose a little bit of vitamins, you lose some B vitamins, some vitamin C, but you don't lose those phytonutrients that we were talking about. Those are really very heat stable. And those are some of the anti-inflammatory compounds in plants that we're excited about in lots of ways for their cancer preventative aspect, the way that they may be a power booster to some of the medications that you're taking, and also because they're good for your blood vessels. The final thing I'll say is somebody asked about kind of an anti-inflammatory diet, and maybe there was some discussion with their care team about whether or not there was such a thing. And this is where we could probably just get into wordplay. I think what I would say is that the goal to eat more plants in the diet and eat less processed food is the dietary guidelines for all Americans. We see that this is especially important if you have heart disease or diabetes, or are prone to inflammatory conditions. So we definitely need more research, as always, on very specific diet recommendations that we know could be very preventative and helpful for people with pancreatic issues. But I think as an overall blanket wellness recommendation for diet, more plants is definitely something that will benefit your wellness in multiple ways.
Awesome. You're so good at this. You wish you get your own TV show at some point.
The Northwestern GI.
All right, Dr. Epstein, just a quick question about, all these things you talk about. A lot of them have a lot to do with access to specialists like you. And we know what a precious resource a psychologist can be, especially one who could focus on digestive illness. Can you maybe try to put yourself out of business a little bit and talk about things that are apps that you recommend and things of that sort? I know you sort of touched on it a little bit. I know that Beth has touched a little bit about dietary stuff, but what apps or what resources would you say are online? Because when Dr. Hogg and Dr. Singh try to refer patients to you, I'm going to block it and say no, you got to use this app. So I want to keep it all to myself. So what can they use for some patients as well?
It's a great question. One thing I will say very quickly is that GI psychologists are few and far between, but a general health psychologist is usually very well positioned to manage a lot of the same issues that patients with, chronic health issues have. So that might be an easier route to kind of get in to see a psychologist. Again, maybe it's not somebody who has expertise in the GI world, but, they have education and training on how to manage chronic illness, chronic pain, things of that nature. There's a lot of really good apps out there. Off the top of my head, and I can, look into this and send some additional resources later. But the app that I recommend most often is an app called Insight Timer. It's really fantastic. It's got a super extensive library of guided meditations. It's free. You can search by keyword, which is really nice. So you can search pain, and a bunch of guided meditations are going to come up of all different lengths. And these meditations are user rated. So you kind of know which ones are good and which ones aren't. But you can, try a bunch of them. They're all, again, different lengths with different practitioners kind of leading you through. I think you can pay for portions of it too. I think there's classes that you can take, but the free version is just fine. And it's a really, really nice resource for supporting mindfulness meditation practice. The Calm app is also a really nice one. But beyond that, I'd have to kind of go back to my list, and maybe I'll send that out later this evening, if that would be helpful.
Yeah, I think one idea is, for those of you with really good resources, namely the two of you talking about dietary and GI psychology stuff, maybe you can send a list to Trish and she can send that out with the email she sends out. I'm just going to do a couple of quick questions and one for two of our panelists and put them on the spot. I'll start with you, Dr. Hogg. one of the things that sort of comes up a lot in these questions is, what to look out for, in terms of something not being right with the pancreas disease. Some people who are at high risk for pancreas cancer, pancreas cysts, they always say, oh, what symptoms am I going to have, or what am I going to be worried about? Obviously in your experience, you see people often on the wrong side of the spectrum with new diagnosis of pancreas cancer, like some of us on the panel. Any tips you can share about what they might be watching out for, symptom-wise, that they shouldn't dismiss as they're trying to be proactive about their health?
Yeah, sure. I mean, a lot of things are subtle, but there's just a few main ones. I think that, early or new onset diabetes is something that can be of concern, but, there's a lot of things not related to pancreas cancer that can cause that. But definitely that is one thing to look for. Jaundice, and a lot of people may not notice their jaundice, but, even I'll tell people, pay attention if your urine looks darker or your stool gets lighter, and look around your eyes, for signs of yellowness that may be more pronounced. And then, as our previous speaker, in terms of the exocrine pancreatic insufficiency, in terms of the stools, and stuff like that as well, of pancreatitis is also another sign. But really, and, for any sort of cancer too, any sort of unexplained weight loss, I think that, so many people try so hard to lose weight, you know what I mean? And with all the techniques can't, that really without trying and losing a lot of weight is sort of a worrisome feature. So those are the main ones: new onset diabetes, the jaundice, and the urine and stool changes that go with it, pancreatitis, as well as the diarrhea.
Yeah, that's great. I think similar to what I tell patients as well, which is that you don't really want obvious symptoms, but that loose stools or the new onset diabetes is something we try to pay attention to. So I think that sort of will lead me to, just in interest of time, my last question for you, Dr. Singh, is just talk a little. There's a couple of questions about the elastase and, anchoring on the elastase as the diagnosis of pancreas insufficiency versus not, or because it's not a perfect test, people asking for alternative, tests like a fecal fat collection and things like that. Can you go over again, what should patients expect in the practice when they're talking about pancreas insufficiency and an elastase? What do you do in your practice when the elastase is low? Do you just try them on empiric enzymes and see if they improve? Do you get an MR with secretin? Can you give us a little bit of background of what patients should look for to try to not get misdiagnosed with pancreatic disease or fail to get diagnosed?
Yes, I think the most important part is selecting the patient who needs the fecal elastase checked or not. If we start checking fecal elastase on a lot of patients we see in the clinic for other abdominal diseases, we will find low fecal elastase in a lot of patients and miss a lot of other diseases and just blame everything on pancreatic insufficiency. So I think sitting down with your physician and doing a detailed physical and history is very important, and your physician should go through what makes me think it is pancreatic insufficiency. Do I have risk factors for pancreatitis, smoking, alcohol use, any family history, and have I had any surgeries? Have I had any on the pancreas or the intestine, or any small bowel disease, anyone in the family with history of IBD or Crohn's disease, and diarrhea of other causes? Once those things are ruled out or are factored into, then I think, okay, these symptoms can be because of pancreatic insufficiency, and the quick and easy way to figure out is fecal elastase. But if I'm worried about other causes causing these symptoms, I'm not going to fecal elastase. That is a situation where I would consider stool testing. And if not, at least sometimes there's a quick cheating way of doing fecal stool fat is a single sample of stool fat as well, instead of doing the whole 3-day. But if your physician is asking for a 3-day stool collection instead of a single fecal elastase, maybe they are worried about some other things, other conditions causing fat malabsorption rather than pancreas being the reason for the symptoms.
Fantastic. Well, I think it's lead us with one more minute to say that I want to thank everyone. Trish, if you want to come on camera too to to thank you as well for organizing this, and maybe you can give a final word and plug for the NPF and the resources.
Yes, thank you so much. I appreciate all the information provided by the panelists. It was an excellent presentation. Just wanted to let everyone know that we will send out a link. This will be uploaded to YouTube, and a link will be sent to you in the next couple of days, as well as any other additional documents and links that might be of service to you. But we want to thank you all for your participation tonight and look forward to seeing you again.
At the gala for those in Chicago.
And if you're in Chicago on October 16th,
15th.
We would love to have 15th on Saturday the 15th. We would love to have you attend the gala. We're going to be honoring a couple of the physicians that are with us tonight that have been excellent examples for the community and been great supporters of NPF. Thank you again.
All right. Thank you.
Thanks. Have a good night.
Thank you, everyone.